Hello, guys. Let's talk about cardiac arrests and what the heck's the point. So, one thing I see a lot is that we hyper focus on the algorithm and we work through the algorithm. The ACS algorithm has been drilled into our noggins, especially when we first get out of school and especially when we get out of paramedic school. And I think because we focus so hard on the algorithm, we forget the whole point of cardiac arrest resuscitation. That is, besides getting the heart started back. So the whole point is to identify the reversible cause and treat that. So it's not about just giving a ton of epi, doing a bunch of compressions, and hoping for the best. Obviously, in cardiac arrest, your number one resource, your number one means of reperfusion or maintaining perfusion is CPR, chest compressions. So we obviously need to focus on chest compressions. Chest compressions save lives. We got to do it. We got to make sure the blood is going round and round. I think that because we focus so hard on the algorithm, we kind of forget about our H's and T's. We know they exist, but we're just like going down the list. Okay, let's hit all these H's and T's. And not necessarily do we need to administer medications or interventions that are going to eliminate every single H's and T, especially if we have a good idea of what causes cardiac arrest. And I know that you may have heard people say cardiac arrest is the easiest call you ever work. And I agree with that, but I also disagree with that because, yes, in essence, we know exactly what to do. We know the algorithm, we know the steps, but it should be a really critical thinking call. What are these patients' medical history? What comorbidities do they have? What was happening leading up to this event? We need to do some investigation. And because we have an algorithm and we have a process, and this has been drilled into our heads, we're able to take a step back and say, okay, we have the patient on a Lucas device. We have them on some kind of mechanical CPR device. All right. Hopefully that is something you have at your agency. We're managing the airway. We may be ventilating with a BVM. Maybe we've placed an airway adjunct like an iGel, or we've intubated. And that kind of helps us cognitive offload. Now we're able to take a step back. Obviously, we're still following the algorithm, but once we all have these things in place, and we're able to think a little more critically because there's less going on in our brain. There's not just all these tasks floating around up here. We're able to say, okay, this is what's wrong with my patient because X, Y, or Z. The patient told his wife, my chest hurts and collapsed. Maybe the patient has missed dialysis all week. Maybe the patient was doing drugs. Maybe we have identified drug paraphernalia on scene and we're able to identify the cause of the respiratory arrest and then cardiac arrest. So use your context clues. I know that sometimes we just don't know anything. We just show up to scene and it is chaotic. No one knows anything. They found the patient down. They weren't complaining of anything. And then all of a sudden, boom, someone gets a call for cardiac arrest, CPR in progress. Which, when you think about it, all of a sudden they were fine and they collapse. We have some idea that maybe this was a sudden lethal dysrhythmia. Maybe this was a aortic aneurysm rupture. Maybe this was something like a massive MI. This is something that caused sudden cardiac arrest. So we may have an idea. So you guys are smart. Use your critical thinking and remember that just because there's an algorithm doesn't mean we can not go beyond that. So I like to say that the algorithm or the protocols, those are your floor. You can bust right through those. And if it's something crazy, you've learned something, you found out some specific about this patient, and you're like, you know what, I know how we can fix this. There's no harm in calling for orders. You can do that as well. But I just really wanted to hit home and open up the floor for conversation about how we address cardiac arrests. It might not be the easiest call you work because critical thinking can be exhausting. But just remember, do everything you can to cognitive offload, in my opinion. For example, there are some studies that show there's no difference. There's absolutely no difference in doing manual CPR versus mechanical CPR. For me, you have to look at that in a more dynamic way. So if we're in a hospital where we are able to exchange compressors, and we have a line of people who are able to hop on the chest and do compressions for 2 minutes before swapping out, that's great. You're going to have great results with those compressions as long as those people are competent. That may not always be the case in the pre-hospital setting. We don't always have perfectly flat surfaces. We may not have the patient in a way that we can access them successfully enough to do compressions. Like you're in a small space, we have a patient who's trapped, etc. There's just so many reasons that I believe that mechanical devices are wonderful. They're wonderful for pre-hospital because we don't have as many resources as you're going to have inside the walls of a hospital, and it cognitive offloads, which is something I talk about a lot. I've already mentioned it a couple times in this video, but cognitive offload. And if you have a partner that you're with every single shift, talk about your plan. What is it going to look like for you guys going into a cardiac arrest? If you are the same license level, who's going to get information from the patient? Or from the patient's family? If the patient is giving you information on a cardiac arrest, newsflash, it's not a cardiac arrest. Anyway, who is going to be responsible for airway? Who's going to be responsible for the IO or IV? Just have that process nailed out. You're going to do it the same way every time with your partner. Again, cognitive offload. So we can focus on these really complicated patients. Patients who go into cardiac arrest are not usually perfectly healthy. So there's a lot of complexities. There's a lot of things that could be confusing or contradicting. So just hammer in your methodology, know your partner's moves, know your moves, and know what agencies could be responding and what their moves are going to be and what you're going to need from them and how you guys can work as a team well, so you can critical think and do the big brain things that it is to be a paramedic, because you should be doing big brain things on cardiac arrest. So I would love to hear any recommendations you guys have, how your process is for cardiac arrests, things that you've learned along the way, tips or tricks that have made cognitive offload easier for you and your partner, anything that your agency has implemented for cognitive offload. And if you don't have these methods in place, I encourage you to go to your services and advocate for these changes. Advocate for the, mechanical CPR devices. Advocate for the best equipment possible so you can focus on solving the puzzle.